Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. Today we're discussing an HDC case that involves ED, cardiology and a trainee intern, where resource constraint had a role to play. My name is Dr. Sam King and I'm a medico-legal consultant with MPS, and my background is general practice, and I'm very fortunate to be joined today by a number of colleagues. Firstly, we've got Lucy Gibbard, who's also a GP and MLC. Hi Lucy.
Hi Sam.
And Dr. Tim Cookson, who many of you will know, who has a background in general practice and as an MLC, was an MLC who's recently retired. Nice to have you join us, Tim. I'd also like to welcome Dr. Chao-Yen Chen, who works with me at MPS, and she's an anaesthetist. So it's great to have you here, Chao-Yen.
Hi, Sam.
And last, but certainly not least, is Mr. Adam Holloway, who's a partner at our panel law firm, Watton & Carney. Really good to have you here, Adam, to gain your insights.
Thanks, Sam. It's a real pleasure to be here.
So let's just set the scene. This case took place in ED, and in the ED they were very short of medical staff that day, and it was much busier than usual. So Mrs. A was brought to ED by ambulance with a 2-day history of transient but severe chest pain. The patient was pain-free at the time of admission. The patient was seen initially by a trainee intern, a TI, who's a final year medical student. The patient was walking home when she developed 8 out of 10 chest pain with no radiation. The pain was relieved with rest. She slept that evening and woke for her night shift at work with pain still present. An ambulance was called and she was taken to the ED. At the time she was assessed by the TI, she had no chest pain. She had no previous cardiac history but did have a high cholesterol, was a smoker and a strong family history of heart disease. Examination revealed a new aortic heart murmur and an irregular heart rate. Dr. B, the SMO, then came to assess the patient. Dr. B felt the ECG was reassuring, and according to the clinical notes as documented by the TI, Dr. B planned to await troponins and to refer to cardiology as an outpatient to investigate the new heart murmur. Dr. B's response to the HDC when the complaint arose stated that his plan was for admission and review by cardiology. The clinical notes for SMOs generally are written by another member of staff, usually the junior staff, and in this case it was probably the TI. Dr. B discussed the case with the cardiologist and registrar who happened to be in the department. Dr. B asked for the patient to be admitted, but there is no documentation of this discussion. According to Dr. B, the cardiology team declined to see the patient as blood results were still awaited. He wasn't surprised because blood results hadn't arrived and cardiology are very resource constrained. According to the cardiology SMO and registrar, however, no formal referral had ever been made. They viewed the conversation as being more of a heads up rather than a referral. They thought that formal referral would be made if the troponins were positive. If they did not document they didn't document the discussion at the time, and no review took place. I think you're already hearing a theme about the no documentation taking place. So the troponins did come back and they were mildly raised at 22, the upper limit of normal being 13. So Dr. B advised the HDC that he asked the trainee intern to advise cardiology of this result and to ask them to review Mrs. A. The trainee intern responded to the HDC that this was actually never requested as far as he was concerned. Dr. B recalled that the trainee intern advised him that cardiology declined to see Mrs. A and requested a repeat troponin. Dr. B stated that he would have then asked the TI to repeat the trope, but the TI again denies this took place, and again nothing was documented. Mrs. A then had another episode of chest pain and GTN spray was given. However, this wasn't documented by the nurse. An ECG and further troponins were taken. The TI documented that analgesia and antacids were given, and Dr. B was never advised about the patient's chest pain. The second troponin was essentially unchanged, and Dr. B recalls speaking to cardiology, who advised an outpatient review in light of the patient's stable troponins. The trainee intern and cardiology team have a different view. The cardiology team denied being notified of the troponins at all. What is documented just prior to the patient discharge was where Dr. B wrote, "Brief discussion with cardiology reg, followed up by TI. The plan for outpatient cardiology was reiterated." Mrs. A was then discharged from ED and sadly suffered a cardiac arrest a few hours later and died. The post-mortem found the cause of death was ischemic heart disease, and the case was referred to the coroner, who referred the case to the HDC. And the hospital carried out a critical incident review. And this review really raised three issues around documentation, communication, and the specific clinical pathway that the patient was on. So, Lucy, can I ask you, how often do we see documentation issues with consultants or SMOs in the hospital? And what do you think were the issues for Dr. B regarding documentation?
Well, I think we see quite a lot of documentation issues for SMOs in the hospital, particularly in these situations where it's not a formal ward round, it's not a formal outpatient setting, it's a discussion in ED. Or a discussion in theatre or a discussion in the corridor, the commonest times when, in fact, the documentation can be lacking. In this particular situation, it seems like the TI actually did most of the documentation. And the question always is have they documented accurately what the SMO intended them to write, and did the SMO check it? Because obviously a TI is actually still a medical student, not a registered doctor. And, even though it is common for them to scribe, it is really important that the SMO actually reviews what the TI has written and checks that it is accurate and everything is being properly recorded. It's really hard. You can see this busy ED. There's not enough medical personnel. The TI is being treated as if they're a doctor. And so you can see how it happens, but actually from the SMO's point of view, his vulnerability is being created by the fact that he probably never checked those notes at the time they were written. We don't know that for sure, obviously. As we were saying, that whole thing about conversations that are less formal tend to be the ones that aren't well documented, and sometimes they can be really important. Conversations with patients and their families, with other clinicians. We often find that the doctor can recall very clearly having had that conversation, but there's nothing at all about it in the notes. And that is often where the HDC is looking to see what was said, and relying on memory. As in this case, often the two sides of the conversation have a different memory. So it's really difficult if it's not documented. You're only as believable as you can be, but if two people have a different view, it's impossible to know what actually happened. Obviously, the busyness of this ED department is part of the problem with documentation as well. But look, at the end of the day, we so often help doctors and there's no documentation, and we end up saying, unfortunately, I didn't document this, but I can remember saying, and we can do that, but it just doesn't have the weight that as if it was actually written in the notes at the time. So yeah, I think it's the MPS mantra, isn't it? Document, document, document.
In the hospital system, Chayen, is it easy for someone to go and document in the notes? Like in a GP practice, it's, you just go to your office and you type up the notes, but I assume it's quite different in a hospital situation. So is it, from a practical perspective, does it work?
Well, a lot of hospitals now have switched to an electronic system, and it's all on computers. And sometimes the computers are at a distance from where you're providing patient care. So you've got to leave the patient, go find a computer, log on. Depending on how fast the computer is, it can take a while to log in and then make your note. So in those systems, I find that everything you do, whether you're checking results, looking up observations, heart rate, temperature, is away from the patient. So you're not really at the bedside when you when you're collating this information. So it's harder. There's an extra step to make a documentation. So if you're busy, you're holding it in your head, just thinking, I've got to write this down. Sometimes it just gets busier and busier and you just don't get to.
That makes sense.
Yeah.
Yeah, it's just practically very difficult. So, Adam, given the poor documentation, how credible is Dr. B's account given the trainee intern and cardiology team have a different account?
Well, it's hard in the HDC jurisdiction. So how we as lawyers, or more importantly, how a judge might assess credibility is often through seeing a witness in person give evidence and having that evidence challenged by way of cross-examination and also being able to compare that to another witness who might be saying something different and then choosing whose evidence to prefer. So if this had gone to an inquest, then that's the sort of process that would have unfolded. The HDC complaints process is entirely in writing, and so it's really almost impossible to assess credibility in that classic way. You might have a patient who's a doctor rather who says, "Look, I really do remember this lady because," and give a reason, and it's stuck in my mind. But at the end of the day, the HDC is got a number of clinicians saying different things, and they will inevitably put the most weight on what's written in the notes. It's very seldom that we, if we're helping someone through one of these processes, can find where there's a missing note, to try and find something that's recorded somewhere that will corroborate their memory and allow us to persuasively say that the HDC should rely on what they recall rather than what's written down. As Lucy said earlier, document, and at least as a starting point, be telling yourself, if it's not written down, it didn't happen. Yes, we can have a fight about that later, but that's the safest way to look at the problem from the get-go. And once it's written down, you're always going to win that argument.
So maybe it is that the SMOs in particular need to find a way to document, even if they don't have a computer with handy. I don't know if anyone actually even uses paper and a pen anymore, but you just wonder whether that would be sensible for them to write something down and then ask their PA. I don't know if SMOs have PAs in hospitals.
No.
Well, ask the poor TI to document it for
but
you.
the other thing is actually that checking thing, because I've had a case where the SMO was in a ward round, gave instructions. The house surgeon documented what they heard as the instructions, and later there was something missing on those instructions that the SMO was sure that they told the house surgeon, and the house surgeon was sure that they didn't. And the house surgeon's beautifully documented list of everything the SMO said was taken as the truth. And the SMO had never checked that. So if the SMO had seen it and said it, they'd have seen, if they'd looked at it, they'd have known that. But actually they didn't check what the house surgeon had written as their action plan. So it is that thing about SMOs checking what's being written on their behalf, really.
So, Tim, complainants very rarely make any complaint about the quality of documentation when they write to the HDC. Do you find it's common for comments to be made about the quality of documentation when the HDC give their opinion?
Very common, yeah. And I think it's because the HDC doesn't look just at the circumstances of the complaint. It's got the ability to look wider. And documentation is regarded as being part of the overall quality of care provided. And so if the HDC is asking, was the care of a reasonable standard provided, but the documentation is exceedingly poor, then they're much more likely to come to the conclusion that actually, no, this is not a reasonable standard of care because the documentation is poor.
And so would doctors be found in breach of the code for poor documentation? Have you had cases where that happens?
I think technically they could be, in the sense that good documentation is part of a reasonable standard of care, I think that's very unlikely to happen in isolation of something else going wrong. If a complaint's been made and at that triage stage the HDC has only identified documentation as the only significant problem, it's probably unlikely, I would say, given their workload, that they would progress that to formal investigation. But that's not to say that there isn't that possibility. And if there's another care problem which is deserving of a breach, you may attract an additional breach or adverse comment for the quality of your documentation.
Certainly adverse comments are very common, aren't they, from the HDC on the quality of documentation.
Do you think it increases the likelihood of a referral to the medical council from the HDC if the documentation's terrible?
Yes.
Yes.
Insofar that the implication is that if the documentation's terrible, then the care was probably not that good either. It's a sort of extrapolation from that.
But it is often something that the medical council is then going to look at. Documentation is one of their...
Yeah, and there's two ways to be referred by the HDC onto the medical council. One is proactive, if the HDC gets something that's caused real alarm. And the other is that any case that moves from triage onto investigation, every one of those will automatically be notified to the council. But if there's already a comment in there or information as part of that referral to suggest that clinical note-keeping is a problem, I think the issue is not so much will I get referred to council, but what will council do? Because council can either say, thank you for the notification, we'll wait till the end of the HDC process and revisit this then, or they can say, this is worrying, we are going to look into your performance and your competence independently now, irrespective of how the HDC process is progressing.
Chow Yin, what do you think are some of the reasons for the type of miscommunication that happened here between Dr. B and the cardiology team? Do you see that often in the hospitals?
Yeah, I think any time where you speak to a colleague and, like Lucy says, if it's informal or formal, or you're passing them on a busy shift and you're saying, oh, I've got a case for you, I've got a patient for you, and they just say something back, it is easy to miscommunicate or mishear, and it happens all the time. And I think some hospitals have very clear processes, for example, at registrar induction, where they sit everyone down and say, I remember an orientation I had as a registrar where the ED charge clinician sat us all down and said, when ED refers you a case, it is a referral. You must come see the patient, and you cannot tell us to talk to someone else. We are referring to your specialty, full stop. And so that was the process there. It's very clear. It's laid out in stone. And so you don't get the situation where the person receiving the phone call goes, oh, I don't think that belongs to surgery. I think that's much more an orthopedic problem. Or, oh, I think that person's abdominal pain is not surgical. I think you should call gynae. And then the poor ED person is phoning lots of different specialties.
Sounds like what happens to GPs.
Sure does.
100%. That's right.
Get past the post.
Yeah. And also in this case, some hospitals where some hospitals, some chest pains go under general medicine and some go under cardiology. I don't know what the case is here in this hospital, but the cardiologists might have gone, oh, doesn't sound too concerning for a cardiology issue. Can you just review them, and if you just send them home? And the ED physician might have heard something else. So in this case, I guess they were concerned, thought they'd made the referral, but cardiology thought they were going home.
So
Ian, would you expect the referral to be in writing somewhere? Or
No, not
verbals?
always. No. So in some places you have an electronic whiteboard, and then after your discussion you put down whatever specialty you've spoken to, and you're in the ED, from the ED perspective, if they've been referred, you write it on their board. But from the specialty perspective, if they don't think they've accepted the patient, then they don't think it's being referred to them. So they think it's still an ED jurisdiction. So it's quite complicated.
Yeah, so so ideally, each hospital would have a protocol and a process that was accepted and recognised, so that it's clear when a referral has been made.
That's right. Ideally.
Okay, that's interesting. Interesting to hear your perspective. I guess too, I mean, it would really help if there was some closed loop communication in this case, where it was like, so you're accepting the patient? Yes, I am. You know, something like
Yes.
that. Something as simple as that, especially if it happens really commonly, and then patients wouldn't fall through the cracks so much. Interesting. Tim, Dr. B asked the trainee intern to liaise with cardiology. Are you aware whether it would be common or appropriate to have the TI do such a thing?
Look, I don't know how common it would be. I suspect here maybe there was no house surgeon, and hence the trainee intern was kind of acting as a house surgeon. But it does make you feel really sorry for the position of the TI in this case, because they're the bottom of the rung, and yet being put into a very difficult position through the complaint, but also in the process of the consult. And no, I would have thought that if you've got someone who's sick enough that you're needing to refer to a specialist service and there's a specialist available, the ED SMO, then it would be the ED SMO who should take responsibility for that. Or if it was for purposes of training the trainee intern, he could say to the trainee intern, okay, I'd like you to ring cardiology. I'll listen in and make sure that your call is appropriate. But it should be with very direct supervision, which is what trainee interns need, direct supervision. And clearly that process didn't happen.
Chayan, do you have any advice for TIs in this situation?
Yeah, I think it's absolutely reasonable to say to your team, certainly at the start or when you're being asked to do something that you're not sure about, to request that supervision that Tim was talking about, to say, I'm happy to learn. I'm really keen for any experience, but please would you be able to listen in on me having the conversation and take over at any point? Or can I write what I'm going to say down and you review it and then I say that, so that you're sure about the information you're being expected to relay? And then it's much more constructive and you're not left wondering whether you've passed on the right amount of information or potentially leaving something out that might be important.
I also wonder whether cardiology found it easier to say no to a TI
Absolutely.
than an ED consultant. I actually often feel very sorry for the juniors because, as a TI, talking to a consultant, there's a huge power imbalance there. And I would have thought that there may be situations, and I'm not sure, I don't know what happened in this situation, but there may be situations where the consultants find it easier to say no to a TI than to a consultant colleague. And as you say, the TI may not know exactly what bits of information are the bits of information that are going to press the buttons to get an admission, whereas an ED consultant probably would know that. So I think the TIs are really disadvantaged from that, and more likely to be rejected, to be honest.
I don't know how detailed the policy document is, but I understand from a recent inquiry that I had from one of our members that TIs do have a booklet that they need to read when they start at a hospital, and that sets out what they can and can't do and protocols around when they can step in to help and when they must not. And I have no idea, but I wonder if that's actually part of that protocol, because if it is, if they can say to the SMO, well, the TI handbook states this, that would probably give them some strength. But otherwise, you're right, they're in a terrible situation if they're not sure. And nobody wants to seem like they don't know what they're doing, particularly at that stage in your early career. So, yeah, it must have been very difficult.
I think if you know that the specialty you're trying to refer to is resource constrained and is pushing back, then that, irrespective of the facts of this case, just speaking from a practical perspective, as an SMO, it would probably should be factored in as to whether or not it's you who makes that phone call. If you think it's important that this person is referred that night and not given an outpatient appointment, then maybe it does need to be a SMO to SMO conversation.
So if we move on and talk about the impact of resource constraints, and I know we've had a number of previous podcasts that have touched on this, but for those who might be listening to this for the first time and haven't listened to those other podcasts, Adam, would you mind just explaining how the HDC view complaints where resource constraints are a contributing factor?
Yeah, so the HDC code, which sets out the rights providers are expected to comply with, includes the following comment. A provider is not in breach of this code if the provider has taken reasonable actions in the circumstances to give effect to the rights and comply with the duties in this code. And then the circumstances is defined as meaning all relevant circumstances, including the consumer's clinical circumstances and the provider's resource constraints. So it's always available as part of your response to a complaint to say, well, I took reasonable steps in the circumstances. My circumstances at the time included this really significant resource constraint. So extrapolating from the facts we're discussing earlier, the cardiology service was overwhelmed and they weren't able to see people with only mildly raised troponins. While that is what the code says, in my view, it's certainly not a get out of jail free card by any stretch. The commissioner and the commissioner's office, when undertaking an investigation, will only walk back from what might be a breach finding in relatively limited circumstances, in my view. So just before coming here, I did a quick check. So I just searched all of the commissioner's opinions for those words, resource constraints, and 82 came up out of all of the opinions since the start of the commissioner's jurisdiction. I can't tell you off the top of my head what the denominator is, but it's a relatively small number of opinions that mention it. And then I looked at the top 10 by date of those, and there were only two, it seemed to me, where there was quite a clear finding that this was a resource constraint situation and therefore we are not going to find a breach. And in all of the others, either resource constraint was advanced but not accepted, or it was advanced, accepted, and they still found people in breach. And often the service will be found. Sometimes the commissioner will say, well, okay, this particular doctor, we're just going to give an adverse comment, but we still find the service in breach because, and I understand this from some perspective, I don't think the commissioner wants to get into the position of saying suboptimal care is okay. So you're more likely to get a finding to say, I see that there are resource constraints, I acknowledge them, but everyone is entitled to good quality care, service is breached. And whether or not that will then extend to the doctor, you might have a slightly stronger argument, but I think you're always on the back foot if that's your defence. It's by no stretch common for the commissioner to let people off the hook for resourcing reasons.
And in this case, I guess the resource constraints also apply to Dr. B, don't they? Because the ED was particularly busy. And if he normally had a house surgeon to work with him, but in this case was only a trainee intern, then that's another resource constraint. And in that kind of situation, we always try and get as much information as we can about just the degree of busyness. So finding out how many patients were in ED at that time to be able to prove to the HDC that this was actually way outside the normal expectations, and therefore it was much more difficult to provide good care in that circumstance.
I think for that reason, it's always helpful, isn't it, if you can remember to document if it was a particularly difficult day, that day, you had extra patients, it was extra busy, or you had far fewer staff than normal. I think it's helpful to maybe just make a little note of that. So
more documentation, Sam.
Oh, yes, more documentation. Yes. So I thought it'd be good to explore the three areas where care was substandard, and according to the HDC anyway. So Adam, would you mind just talking about the documentation and the view that the HDC took on this?
Yeah, the HDC commented in this opinion that the poor documentation was influenced by the busy department, but that was still unacceptable. So that's an example of acknowledging the resource constraint, but still not being prepared to accept it as an excuse. And that's because it was all staff and not just Dr. B that this was deemed a hospital systems issue. So that's an example where, again, they were prepared to use that resource constraint to bring the breach finding away from the individual and say, well, we still expect the system to be able to provide good care, even if this individual person was prevented from doing so because of their busyness at the time. The HDC felt that the most serious issue of concern in this case was that Mrs. A was not reviewed by cardiology and, as a result, wasn't considered for admission when the consensus is that she should have been. And there's a degree of hindsight in that, obviously, given the outcome. And I think from Dr. B's perspective, there was probably an issue in his mind as to really whether or not he could have persuaded cardiology to ever see this patient in hospital given her presentation, or whether he was always going to be offered an outpatient, even if the loop of communication had been closed, but we'll never know.
Thanks, Adam. Lucy, do you know what the HDC commented on regarding the communication?
Yeah, well, clearly there were communication issues between the departments here, and what the HDC stated is that overall, I accept that Dr. B identified that Mrs. A should have been considered for admission, but I am not satisfied that he took sufficient steps to ensure that this happened before she was discharged. However, even if Dr. B had advocated further, Mrs. A may still have been declined admission, which is Adam's point. And I note that Mrs. A was referred with urgent priority to cardiology outpatient clinics shortly after her discharge, which shows that there was an appropriate consideration for Mrs. A's clinical needs once Dr. B felt that she was not going to be admitted as an inpatient. So basically they were saying, that he should have done more to try and ensure that she was at least considered for admission.
Yeah, I thought it was interesting. When I read this opinion, I thought actually the HDC were quite benign in their approach. I don't know whether you have that view. Adam, you know a lot about this case.
Yeah, I think it was it was a mindful opinion, and it was well balanced. And I think perhaps part of the reason why is that Dr. B put a great deal of effort into, in a very professional and neutral way, explaining what the clinical pathway issues were and what the resource constraint issues were for that particular service, well, that hospital, and then the link through into the cardiology service. And that great deal of work would have been viewed, I think, by the HDC as being valuable and demonstrating how much, to what lengths the clinicians were prepared to go following a really horrible outcome like this to try and shine a light on what the issues were and how they could be improved.
Tim, the third thing that the HDC considered was the pathway that the hospital had for chest pain. Would you mind just describing how the HDC viewed this?
Well, in the response, the hospital stated that due to resource constraints, it had been agreed that not all patients with raised troponins would be admitted to hospital, and only those with a troponin above 20 would be admitted. And I noticed this woman had a trop of 22, in fact 2 of 22. However, in practice, the cardiology department often declined to see patients with troponins over 20, and so they made kind of ad hoc, unofficial changes to the pathway, and these had been made without consultation. And so cardiology had made a unilateral decision, but there'd been no consultation and no agreement with the referring agency, of course, which is ED. And the HDC was very critical of that, and concluded that despite the resource constraint and the practice of not accepting patients for admission despite protocols, however, even despite all that, Dr. B still had an individual responsibility for advocating for Mrs. A.
Yeah, it's quite an interesting thought. It must be very hard for the clinicians where you've got an ad hoc process where you know that in practice, invariably these patients are going to be declined, and that the protocols, as they are documented, don't really apply. But yet Dr. B was held responsible and thought, actually, you're supposed to advocate for your patient. It's a little bit like what happens in primary care, isn't it? And places a lot of responsibility on the individual clinician who generally can't do much about it.
Yeah, and from Dr. B's account too, he had the information that cardiology had declined the admission. That, of course, was disputed by cardiology, but he'd been given that information. And so, yeah, he was in that unfortunate situation of, well, what's the next best thing? And doing the next best thing. But clearly the HDC, and who knows, guided by how much hindsight bias, decided that was not appropriate. What if this woman had survived, but a complaint had gone in because of the delays, whatever? Would the same finding have come through? But as Adam said, Dr. B wasn't breached, but he certainly had an adverse comment.
So, Adam, do you know what the final outcome was with the HDC's opinion?
So Dr. B conducted an audit of all patients over an 18-month period with 2 low-level and stable raised troponins, and submitted that to the HDC. The fact that he'd done that and put so much effort into investigating problems with the pathway in addition to other mitigating factors meant that, as Tim said, he wasn't actually found in breach but did receive an adverse comment. The hospital itself was found in breach. Multiple staff had poor documentation, and the HDC was also critical, as has been said, that there was an ad hoc process that had developed for admitting or declining to admit patients that had departed from the protocol, the formal protocol that was in writing. One part of the opinion that's perhaps worth reading out is, I consider the hospital was responsible at a service level for its system and communication breakdowns that led to the failure to review Mrs. A for admission. The system allowed for clinical decisions to be made with too much weight given to resourcing capacity considerations and not enough to the clinical needs of patients. I consider that the quality of Mrs. A's care suffered as a result of this, and that the hospital systems were a key contributing factor to the inadequate service she received. Accordingly, I find the hospital failed to provide Mrs. A with service of an appropriate standard and breached the code. So that's an example where I think, as is common, the HDC at a service level will not endorse poor care, even if that has been driven by resource constraints. As we move probably into at least another couple of years of very severe resource constraints in the public system, it'll be interesting to see whether this line is held or whether there is a softening of view from the HDC given the crisis in the public healthcare system. We wait to see. But certainly I doubt that as the team of people, both MLAs and lawyers, supporting members through complaints, resource constraints aren't going to go away as an issue for us, as something that we do have to point out as being at the root of many of the problems that people encounter.
I do wonder in this case what would have happened if the cardiologist had seen the patient, seen those two trops that were mildly elevated, and decided actually on clinical grounds that this patient didn't need admission. Would that have, because, they were outside their protocol, but they had made a clinical decision, would that have been all right? And how much the resource constraints is the issue, so much as the fact that actually she wasn't given the chance of the assessment. Because of resource constraint, I suppose. But
Yeah, I agree. And I think the thing, as you say, Adam, resource constraints are here to stay at least for a while. It is normal. And I guess it's about hospitals and primary care making the most efficient use of the resources that we do have and doing the best we can. And I think it means really thinking about the efficiency of the systems we run. Have we got the right protocols in place? Are our staff sufficiently trained to deal with this current environment?
One of the interesting things I find sort of reading these cases and thinking about them is, did these circumstances arise as a result of a pattern of activity that had been going on, and it just happened that this was the case that showed it up? Or is this an outlier, and that normally everything works really well, but this, just on this one occasion, it didn't go so well? And I think that's where Dr. B's work in looking in detail at what happened would have helped convince the HDC that, in fact, actually there were some major systems things going on here, and would have, as you say, led them to that conclusion that the system was at fault and that this was not just a one-off, but it was something that needed to be corrected.
Thanks, everyone. So drawing this podcast to a close, I think if we're going to pick anything up from this is, one, that resource constraint is normal, that we just need to ensure that we act accordingly, really, in the best way to protect our patients and ourselves. So documentation is really important. Communication, particularly interdepartmental, is crucial. Particularly if we think about closed-loop communication and following formal pathways of referral. And also thinking about use of junior staff, particularly trainee interns, just ensuring that we're not working outside of our scope and our level of qualification, as tempting as it is when things are tight. So thank you all for joining me for this podcast. And thank you to our listeners. I hope it's been helpful. Our next podcast will be coming up in 2 weeks' time, and we hope you can join us for that. We look forward to catching up with you soon. If you like the Medical Protection Podcast, please subscribe and leave a review. If you would like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org.